I'll request Sandeep to cover the last topic as far as the lecture is concerned, that RCM versus CCP. Again, a very, very common thing during the exams, often asked, and majority of you guys fumble at that point only. So I request that go through this lecture nicely.
Oh, thank you and good morning. Uh, so, good morning. Uh, this is uh, this is actually one of the toughest differentials, and Shiv Kumar is my batchmate. He gave me this topic. I tried to run away from it. I said, "Look, I can't come on Saturday." So he said, "Okay." He put me on Sunday when I was to come. But believe me, uh, I'm almost learning along with you guys as we go along talking about this. There are two important articles which I can share uh, with the company people, and they can share it with you. There is a 2016 JAC article which talks of differentiating between chronic constrictive pericarditis and restrictive cardiomyopathy. And there is an article from the Heart, which is the British journal. And a lot of what I have taken here has come from these two sources. So the important thing is, why, first of all, why is it important to differentiate between these two conditions, constrictive pericarditis and restrictive cardiomyopathy? The first thing is, and the Jack article writes that as the first line, this remains one of the cardiovascular medicine's most complex challenges to differentiate between the two. Both the conditions have impaired filling and predominant right-sided features. The important thing is constrictive pericarditis is a reversible disease, whereas in restrictive cardiomyopathy, by and large, it's a inexorably unrelenting course, and the patient is likely to, have not a very good prognosis. And constriction, as we know, is basically encasement of the heart. The pericardium gets thickened; it does not allow the heart to expand. Uh, those of us who like to study cardiovascular physiology, we understand that tamponade can occur even with, 50 ml to 100 ml of extra sudden bleeding into the pericardium. But on the other hand, all of us have tapped at some point of time in our lives or the other uh, very large pericardial effusions which are going into tamponade. And this phenomenon of pericardium getting stretched out over a period of time is called creep. And this is mentioned in Brown-Wall's textbook of physiology. So in chronic constrictive pericarditis, on the other hand, there is a thickening of the pericardium, so the creep never happens. It cannot happen because of the constriction by itself. Whereas right restrictive cardiomyopathy is a disease, as we understand, of the myocardium. Now, please forgive me because there are going to be some overlaps as I present along, because it is difficult at times to tease out each point, and so when you cut paste, there will be some bits of overlap. So bear with me for that. Now, as far as the etiologies of these two conditions is concerned, in our country, the most important cause of constrictive pericarditis, as we all know, is tuberculosis. Whereas in other countries, and at number two in our countries also, you would have uh, problems like due to radiation, due to connective tissue disorders or patients having undergone previous cardiovascular procedures. Restrictive cardiomyopathies, on the other hand, they have a separate genetic group of diseases which cause it. The in the rest of it, most common is idiopathic. There are specific like amyloidosis, and we are aware of conditions like endomyocardial fibrosis and endocardial fibroelastosis. Uh, this is an elegant article on, it's a review article on restrictive cardiomyopathy, which tells you that you have, certain genetic syndromes and non-genetic syndromes in each category. And amyloidosis and some storage disorders and familial restrictive cardiomyopathies are the important causes in the West. We have, more importantly, the tropical endomyocardial fibrosis as the cause of restrictive cardiomyopathy. In this slide, I have tried to, recapitulate with you guys the uh, the jugular venous tracings that we all know. So the first thing that we see here is the A wave, which corresponds to the atrial contraction. After that, the atrium starts to relax, and so we have the X descent. X descent. As soon after the atrial contraction, the ventricle starts to contract, and during the phase of isovolumetric contraction of the right ventricle, there is a bulging of the AV area into the RA, and that causes the C bump as we know of. After the X descent is uh, completed, we have continuous filling of the ventricle, and after some time, this filling completes and we have the V wave. And when at the end of the ventricular systole, uh, the ventricle again relaxes, we have the Y wave. So this is the normal physiology. Now, in case of constrictive pericarditis, these two are extremely important. As we know, when we inhale or during inspiration, the venous return to the right side of the heart increases. So in case of a normal person, this leads to actually transmission of the intrathoracic pressure from the heart. It gets transmitted to the heart, and so we don't get any rise in the JVP as we inhale. In case of constrictive pericarditis, we have this Kussmaul sign, which is increasing JVP with inspiration. Now, there is another important sign which is called the Friedreich sign. Uh, in constrictive pericarditis, we have a prominent A wave, we have a prominent X descent, and we also have a prominent Y descent. So if you have two prominent descents, then it is constrictive pericarditis. It is also important to remember that the Y descent is a very sharp descent, and it has been described as a flicker. And this flicker is what is called as Friedrich's sign. That is something that some of the examiners may like to ask you. We also need to understand that we have a good X descent because the atrial contraction produces a reasonable A wave, and after that, as the ventricle is as the pressure descends into the ventricle, you get a prominent X. But over a period of time, the atrium is not able to accommodate the blood which has been coming into the right atrium, and so you also have a prominent Y wave. So please remember, if there are two negative waves present, the X and the Y, your patient has constrictive pericarditis. In case of a restrictive cardiomyopathy, there is a single wave and that is a Y wave. The difference between the Y wave of constrictive pericarditis and restrictive cardiomyopathy is also in the type of Y wave that you see. In case of constrictive pericarditis, you will have a flicker, and that particular sign, as I said, is called as Friedrich sign. So this shows the right atrial pressure tracings in uh, cardiomyopathy and also in restrictive cardiomyopathy and constrictive pericarditis. Now, the blue ones are the ventricular tracing, and the red one is the uh, the red one is the right atrial tracing. And as we can see on the left side is constrictive pericarditis. You have a prominent X descent and you also have a prominent Y descent. And we also note that just after the Y descent, there is a plateauing of these, what is known as the square root sign. The square root sign, however, is not a distinguishing feature. It is also present in case of right-sided cardiomyopathy. So what distinguishes is two waves, X and Y, constrictive pericarditis, only Y, restrictive cardiomyopathy. Between the Y waves, why is it important to know? The importance is that if your patient develops atrial fibrillation, then the X descent might go away, but the flicker still continues. So if you have a single Y wave and you want to differentiate between the two, this is the way. Square root sign does not help you in distinguishing between the two. There is, because the heart has been encased, because the heart has been encased, there is also something called ventricular interdependence, which is prominently seen in constrictive pericarditis and less prominently or almost negligible in right-sided cardiomyopathies. So I'd like you to focus on these gray areas. So there is a lot of variation between inspiration and expiration. And in if you focus on these gray areas, there's a lot of differentiation between the pressures in inspiration and expiration. And that is the feature of constrictive pericarditis. And the in restrictive cardiomyopathy, that variation is not really present. So if we try and summarize these findings, if you have prominent X and Y descent, it is likely to be constrictive pericarditis. If you have the other thing, as we noted, is equalization of left and right sided filling pressures. That is again a feature of constrictive pericarditis, and we'll discuss a little bit about this a little while later. Square root sign is again present in constrictive pericarditis more consistently. However, it may also be present in case of restrictive cardiomyopathy, and it does not help you in that. Because there is a equalization of the diastolic pressures, so the filling pressures of more than 25 millimeters are rare in case of constrictive pericarditis, whereas they can be there in restrictive cardiomyopathy. Pulmonary artery systolic pressure, some books give a cutoff of 50 millimeters, as in this case, and some give a cutoff of 60 millimeter. Suffice to say that if the pulmonary artery pressure is high, pulmonary artery systolic pressure is high, then it is unlikely to be constrictive pericarditis. It has to be restrictive cardiomyopathy. And the ratio of right ventricular end diastolic pressure and right ventricular systolic pressure is usually more than 1/3 in case of constrictive pericarditis. Uh, and as I said, the left and right ventricular interdependence is discordant in constrictive pericarditis. So when the right-sided ventricle is small, the left-sided ventricle becomes big because the septum keeps on shifting. So it is It is actually a complex interplay between the respiratory variations and the venous return variations, and also the way in which the interventricular septum behaves. And we shall see that a little while later. So, clinically, if we look at auscultation, these are diastolic phenomena. So, typically, in case of constrictive pericarditis, you have a very early sound which occurs 60 to 100 milliseconds after the second heart sound, and that's a very sharp sound, and that is why this is called as pericardial knock. In the right, in the restrictive cardiomyopathy, on the other hand, you have a little delayed sound, which is like a thud sound, and that is the right-sided third heart sound. Also, please remember that if you have murmurs of MR or TR present, these are very typical of, these are almost never ever there in constrictive pericarditis. So if you find a regurgitant murmur, it is suggestive of restrictive cardiomyopathy. And it is also good to remember that the S4, if you hear a S4, then it is virtually going to rule out constrictive pericarditis. If S4 is present, it is restrictive cardiomyopathy. It is virtually never there in constrictive pericarditis. As far as ECGs are concerned, there are no particular or specific features. However, there are some features which are present in constrictive pericarditis. Please remember that pericardial inflammation can spread into the atria also and can lead to interatrial conduction defects. So you have wide P waves, you have notch between the, in the P wave, and these are low amplitude P waves. On the other hand, restrictive cardiomyopathy is almost always associated with a biatrial enlargement. The LA and RA both are enlarged. Atrial fibrillation can be present in both, but it is more likely to be present in restrictive cardiomyopathy. If left ventricular hypertrophy is present, the features of changes of left ventricular hypertrophy are present in your ECG, then it is restrictive cardiomyopathy. It is also interesting to note that if there is a discordance between the QRS voltage and wall thickness, you should suspect amyloidosis. It is also known that restrictive cardiomyopathies cause conduction defects, ventricular conduction defects, in about 20 to 30% patients, and you may get left bundle branch block or right bundle branch block. But none of these features is distinguishing features. So this is a little busy slide, but this goes on to recapitulate that on clinical examination, Kussmaul's sign, which is paradoxical rise of the jugular venous pressure during inspiration, is usually present. There may be presence of pulsus paradoxus in case of constrictive pericarditis, and both these are infrequent. Kussmaul's is possible in restrictive cardiomyopathy, doesn't distinguish between the two, but it is not very usual to find it in restrictive cardiomyopathy. You find a pericardial knock in constrictive pericarditis, you find a third heart sound, and occasionally a fourth heart sound in case of restrictive cardiomyopathy. As far as the cardiac catheterization is concerned, we all know that equalization of diastolic pressures in all the four chambers. My examiners were very fond of asking which phase of diastole. So I highlighted this. It is the end diastolic pressures. Please remember, when you say there is an equalization of diastolic pressure, your examiner is bound to ask you which part of end diastolic pressure? Is it the mean diastolic pressure? Is it the early diastolic pressure? It is the end diastolic pressure which has equalization, and the difference between the various chambers is of less than 5 millimeters of mercury. It is also important in the same breath to remember, although cardiac catheterization is no longer held mandatory, but in some institutions, like in my place, the surgeon always demands a cardiac catheterization before going for surgery for constrictive pericarditis. So you don't need to do a left heart catheterization in these patients. You can measure the pressure in the right atrium and the right ventricle, and then do the pulmonary capillary wedge pressure, which will give you the LA pressure. So if you have three of the four chambers where you have equalization of pressures and diastolic pressures, that is suggestive of constrictive pericarditis. Echocardiographic features we will see a while later. The dip and plateau form or square root sign, that is another important thing. There are no biomarkers. Please remember, if somebody asks you, is there a biomarker that differentiates? It is important to remember that in constrictive pericarditis, you do not have a rise of biomarkers. Whereas in restrictive cardiomyopathy, you can have a rise in biomarkers like NT-proBNP. So typically, if your patient has a NT-proBNP which is more than 200, it virtually rules out restrictive cardiomyopathy. And typically, the NT-proBNP levels in typical restrictive cardiomyopathy are around 5 to 600. And the reason is that there is a atrial enlargement which is there in restrictive cardiomyopathy. So when we do catheterization, the two other things that we look at is, as I said, the equalization of ventricular end diastolic pressures. They should be less than 5 millimeters, and some books, as this article says, 4 millimeters. And also the ratio of the right ventricular end diastolic pressure to systolic pressure. And that is, again, what I already said. It should be less than 1/3. The figure given here is 0.38. This is a problem in medicine. You don't have very definitive values, and you will have a slight difference in the values from one to the other. Now, let us go to the echocardiography, because echocardiography is another thing which helps you to distinguish CP from RCM. As we see here, this is what is known as the respirophasic septal shift. If we see here, during inspiration, the septum is, this is M mode, and during during inspiration, the septum is shifting towards the left ventricular side, and it shifts to the right ventricular side during expiration. And this particular portion has been magnified here. And what you see here, the shudder that takes place, is the typical septal shudder that you see in constrictive pericarditis. There are other things. So ventricular septal defect, the medial E prime velocity and the medial E prime to lateral E prime, velocity ratios, and hepatic vein diastolic reversal velocities and forward velocities. These are important, and the sensitivities, specificities, and positive predictive values are given here. It is important to remember in this that what are the typical echocardiographic features? You see there is a lot of variation, respiratory variation in the mitral inflow that is seen here. We also see that there is a diastolic flow reversal, which is largely expiratory. It is an expiratory hepatic vein flow reversal, which is seen It is also noted that the E prime is less than 15 centimeters, and in the lateral mitral annulus, the E prime values are even lesser. So these are some of the features of constrictive pericarditis. On the other hand, if we look at restrictive cardiomyopathy, it is important to note that there is a inspiratory diastolic flow reversal. Look at this. This is an inspiratory diastolic flow reversal. The mitral flow velocities do not show any significant variation, and the lateral mitral annulus is, showing even lesser velocities. So the typical feature that you will see on echocardiography of restrictive cardiomyopathy is this typical biatrial enlargement, which is most distinctive. The other features like left ventricular hypertrophy can be confusing. So this is a little busy slide, but it is, I think, the most important slide. When you look at echocardiography, you look at the median E prime velocity. If it is increased, it is favoring constriction. If it is markedly low, it favors restriction. Medial E prime to lateral E prime ratio, if it is increased, it favors constriction. And if it is decreased, it favors restriction. If there is a if there is an increased respiratory variation in the mitral inflow, it favors constriction. And if there is an increased septal shift, that also favors constriction. And if in the hepatic veins there is a decreased forward velocity and increased expiratory diastolic reversal, then it favors constriction. If it is a inspiratory diastolic reversal, this favors constriction. And we shall discuss about the cardiac CT a while later. This is how the X-ray would look like. So you can see that there is the only single thing that you can do is pericardial calcification, you can see. But please remember, pericardial calcification is present in only 25 to 30% of patients of constrictive pericarditis. And this is chest X-ray that is showing pericardial thickness. The same can be done by CT scans. You can demonstrate the thickness of the pericardium. And further down, we have CMR in everything right now. So in constrictive pericarditis, you have a pericardial thickening. In CMR, again, you see those septal kinetics very well. So if you are seeing septal bounce and movement of the septum towards the left ventricle and right ventricle, then this is suggestive of constrictive pericarditis. The ventricular interdependence is also in a similar manner. We also talked about atrial dilatation, which is far more common and far more prominent in restrictive cardiomyopathy. Ventricular hypertrophy, if it is present, it is again suggestive of restrictive cardiomyopathy. And if the systolic function is diminished, remember in restrictive cardiomyopathy, you can have over a period of time a little decrease in the systolic function. However, it is extremely rare in case of constrictive pericarditis. And if we see the late gadolinium enhancement, it will be pericardial in case of CCP and myocardial in case of right restrictive cardiomyopathy. This is, again, this is to show you the encasement. This is the encasement of the pericardium that you see in case of constrictive pericarditis. If you have subacute constrictive pericarditis or effusoconstrictive pericarditis, then you will get the presence of, this kind of fluid also in this. This is a little busy, so let me go and shift. So final two slides. As far as the differentiation between constrictive pericarditis and RCM is concerned, as I said, it is one of the most difficult differentials in cardiovascular medicine. However, in case of patient's history, we will find typically in our country it would be tuberculosis, or the patient having received radiation, or patient having undergone cardiac procedures, and the fourth common would be connective tissue disorders. In case of restrictive cardiomyopathy, it can be familial, or in our country, we have endomyocardial fibrosis, which is common, and amyloidosis is a third condition that is common. In case of jugular venous pressure examination, we find both prominent Y and X in case of constrictive pericarditis, whereas Y is prominent only in case of restrictive cardiomyopathy. The X may be normal or it may be even diminished. Kussmaul's sign, as I said, is more importantly present in constrictive pericarditis, but it does not make a differentiation uh, from the restrictive cardiomyopathy. As far as the lab and ECG and X-ray are concerned, I discussed all that. The comparisons are non-specific. There are no distinguishing features. However, please remember that the positive features are more diagnostic. So if my patient typically has a very high NT-proBNP, he's unlikely to be CP. If my patient has a pericardial calcification on the X-ray, he's likely to be CP. If my patient has left ventricular hypertrophy on echo, then he's again more likely to have, uh, you know, restrictive cardiomyopathy. As far as the investigations of imaging are concerned, increase in pericardial thickness, more than 4 millimeters, pericardial calcification, presence of some amount of effusion, features of ventricular interdependence. I showed the septal movements, they are extremely common, and evidence of pericardial inflammation on late gadolinium enhancement. These are features of constrictive pericarditis, whereas increase in wall thickness, biatrial enlargement, which is very common in restrictive cardiomyopathy, dysfunction, particularly systolic dysfunction, if present, is suggestive of restrictive cardiomyopathy. And the pulmonary artery systolic pressures, we again discussed that if they are more than 60, then they are suggestive of restrictive cardiomyopathy. And as far as the invasive hemodynamics are concerned, again, the respirophasic ventricular pressure differences are important in case of constrictive pericarditis and also to distinguish from restrictive cardiomyopathy. I thank you for your kind attention.
Any questions? Is it? I think it's one of the most important topic, and invariably you will get a case like this in the examination, and there are so many signs that are there in this differentiation between the constrictive pericarditis and restrictive cardiomyopathy, and he has made it very clear. But if anybody has got any questions, I think you have made it very
Yes,
clear and simple.
आप मत पूछना सर,
As a matter of fact, we all come across in our last so many years, all of us have come across the case like this, enigma like this, and we always sat down and sort of put in our brains whether is it a constrictive pericarditis, is it a restrictive cardiomyopathy, and I can tell you now, of course, we have got a cardiac MRI where things become a little bit easier. But otherwise, in the past, the only thing that we could look at the type of pressure tracings that we would get in the pulmonary artery into the right ventricle, into the pulmonary artery wedge pressure. and echo was not coming forward. So I think we had to literally sort of listen to our ears and some pressure tracings. But I think now things have become a little bit more clear, and a lot of misdiagnosed surgeons had gone in, they opened the chest thinking it to be the constrictive pericarditis, closed the chest saying that it was not a constrictive pericarditis. But I think with this kind of science that he has shown, I'm sure you'll be able to make better diagnosis. But I think your aim is to pass in the examination, to tell all these differentiating signs. That's what you should know. Thank you very much, Sandeep.